Welcome to Bio and Beyond podcast. I'm your host, Sawik Nath, and today we're diving into the world of neurosurgery with our distinguished guest, Dr. Vibhor Krishna. He's a surgeon scientist at the University of North Carolina, specializing in deep brain stimulation, spinal cord stimulation, and more. Beyond his clinical work, Dr. Krishna is a prolific researcher with 60 plus papers in top journals. Join us as we explore the fascinating intersection of biology, medicine, and technology with Dr. Vibhor Krishna on the Bio and Beyond podcast. So, why don't you start off by telling us a little bit about what you do?
Thank you, Satvik, for the invitation for the podcast. It's very exciting. And I'm glad that you're doing this great job getting the word out there so that folks who are listening to this can get ideas, think of their own ideas, and maybe even get inspired in the future to pursue one of these directions. So coming back to, I'm a neurosurgeon. I'm board certified in neurosurgery, and I specialize in stereotactic and functional neurosurgery, which is a subspecialty within neurosurgery where we treat conditions that cause functional impairment in patients' lives. These conditions include essential tremor, Parkinson's disease, neuropathic pain, psychiatric conditions, and epilepsy. So to give you a sense, essential tremor is the most common movement disorder in adults. So it's a very common condition. Roughly 4% of individuals over the age of 65 have essential tremor. So it's a very common, commonly observed disorder. And the tremors in patients can become disabling, and eventually patients have what we call medication refractory tremors, where despite medications, they continue to have disabling tremors. And they interfere with things like eating, drinking, hygiene, fundamental things that we take for granted. And other condition that we commonly treat is Parkinson's disease, which is a condition characterized by tremors, slowness, and stiffness, and imbalance. Again, it's a common movement disorder among individuals in their adulthood mainly. And we have very effective medications to treat Parkinson's disease. But as disease progresses over time, patients then develop either side effects from medicines or symptoms that are not responsive to medications. And that's when surgery becomes an option for those patients. Certainly, other conditions that we treat are treatment-resistant epilepsy, along the similar lines that medications become less effective in patients who have epilepsy. Neuropathic pain, which is not treated by medications and other interventions, and medication refractory or treatment refractory psychiatric disorders, especially obsessive compulsive disorder. And the idea is that with surgery, what we are trying to achieve is we are using electrical stimulation or targeted ablation in the brain to restore a physiological state. The way we conceive these neurological disorders is that the underlying pathology, that means the abnormality that leads to these disorders, causes a dysfunction in the brain networks. And this dysfunction then has consequences in terms of patient symptoms and then impairment in their quality of life. And the idea is that using electrical stimulation or targeted ablation of certain brain areas, you could restore the physiological state in a brain network. And so to give you an example, the most commonly done operation that we use based on this concept is deep brain stimulation surgery, where we implant these electrodes in the brain and use electrical stimulation to modulate activity in brain networks and restore a physiological state for patients who have Parkinson's disease or essential tremor another condition called dystonia or epilepsy. The other treatment that we use commonly is called targeted ablation. And so we use different technology to target specific areas in the brain to ablate the activity of that involved region to again restore the physiological state in a brain network. And so if I may, I can use a slide to show the two treatment options that we have today. So we talked about the surgical options. One is the stimulation, electrical stimulation with deep brain stimulation. We use the acronym DBS. And then ablation, the technology that's most commonly used is called focused ultrasound ablation, where we use ultrasound beams to then focus in a specific part of the brain to ablate. Gamma knife is another type of ablation procedure that we use. And in this treatment, we use converging beams of radiation in specific spots to achieve that ablation.
Okay, well, that's really interesting. So, could you tell us a bit about your journey into the field of neurosurgery? How did you get into this?
It certainly has been a process for me. I had interest in neurosciences from early times. I had the opportunity to read stuff about brain function, specifically with inspiration from my mother, who is a psychologist. And as I continued to explore different interests, I became interested in pursuing a surgical specialty. In medical school, I had the opportunity to rotate through different subspecialties and certainly developed a love for the operating room and working in the operating room with different colleagues to try to figure out a solution for the patients who a lot of the times were in dire straits. Simultaneously, I also developed a passion for research, especially leveraging research to improve patients' lives. And so understanding the data at a group level, understanding what makes a treatment work and what causes a treatment to fail. Or also in parallel, how we can optimize our techniques to overall improve patient outcomes. And so those were the lines of research. And so I simultaneously started to train myself in some of these research methods. And right after medical school, I did take a year of master's in clinical research, and then continued my clinical training in neurosurgery, applied for neurosurgery residency, and I was lucky to match at Medical University of South Carolina in Charleston, South Carolina. Did my residency there. It's a 7-year residency where you go through different subspecialties in neurosurgery. And neurosurgery as a specialty also puts a big emphasis on research. And so we do a inbuilt year of research in those 7 years. I requested 2, and I was lucky to get 2 years of research. And so it was a great experience. And then I went off to do a fellowship in stereotactic and functional neurosurgery at Toronto with Dr. Andres Lozano and Dr. Moji Hodai. And with that fellowship, I was able to learn the clinical aspects of functional neurosurgery, but also research and understand how we can optimize different treatments and improve patient outcomes. And so that's my journey. And I joined as assistant professor back in 2015, and currently I'm an associate professor.
Mm-hmm. So you said when you were younger, while you were going through college and housing, you said that you were interested in both neurosciences and research. So how would you say that the combination of both has affected you?
That's a great question. And so, in some sense, my love for neurosurgery stems from that fundamental liking for neuroscience and quest to understand the brain and how the brain functions, and what are some of the changes in the brain that lead to dysfunction, and some of the manifestations that we see in different neurological disorders. And then research is again, uh, different colleagues have different sort of angles as they come into research. And the part that inspires me the most is using different research methods uh, to improve our treatments, to improve the way we do things, and impact patient lives. And so the goal ultimately for the research efforts that we make is to improve patients' lives.
That's interesting. So the fields you work in, they can be really complex topics like neurosurgery and neuromodulation. How do you approach explaining these concepts to the general public?
That's a great question, Satvik, and the important thing is for us to bring the information at the forefronts of neuroscience research, and as we are pushing the boundaries of our understanding, to crystallize that knowledge and bring it to the patients so that they understand what is the basis for some of these treatments and what they can expect. And so, as physicians, the main goal that we have is to connect with our patients. And connecting with the patients require us to understand what they value the most, and understand how they would like this information to be shared with them. And so that's where folks say that medicine is an art, and the art of medicine is involves caring for patients. And so fundamentally, as we connect with our patients from different walks of life, we then use different components of the knowledge to share with them, and make sure that they understand and we answer their questions. Um, some of this we are able to use, say, diagrams, drawings that a lot of our colleagues in medical illustration do. And at other times, we are able to use audiovisual media to make some of these concepts relatable. A picture is more than 1,000 words, right? And so sometimes a picture or a video or an illustration allows us to explain these complicated topics to our patients.
That's interesting. So, can you share some of the most exciting breakthroughs or innovations that you've been involved in or witnessed recently?
Certainly, and so I'm happy to share some of the slides. In my field, there has been somewhat of um, a significant involvement of technology, some breakthroughs that the technology has allowed us to do. And so robots have made a tremendous difference in our precision to do certain surgical procedures. And so here I'm showing a robotic equipment. It has two parts. The part on the left is actually the robot itself, and the part on the right is a navigation device that allows us to know exactly in real time where the robotic arm is in 3 dimensions of space. And so using this robot, we have been able to very precisely deliver therapeutics. For example, deep brain stimulator electrode in my case, or using the robot to implant electrodes to monitor epilepsy. And also, the robots can be used for spine surgery, for example, to deliver the instrumentation very precisely. and reduce the risk of any errors and side effects that come with it. So very exciting advance in neurosurgery that allows us to improve the precision for various therapeutics that are involved in neurosurgery. The other advance in my field is, again, personalization of the treatments. And what we mean by that is to optimize the treatment parameters to patient-specific anatomy, to patient-specific symptoms. And so that allows you to have the maximum impact in their lives. And so one such example of personalized medicine involves using what we call as tractography. And so it's an advanced imaging technique that allows us to study patients' brain connections in detail, much more than what a typical MRI is able to provide this information. There are specific sequences using MRI imaging that allow you to trace these different tracts of interest, if you will. So these are nerve fibers that connect different regions of the brain. And for example, in this one, we are showing in red a tract called corticospinal tract, which controls the strength in arm, leg, and the face. And in blue, we are showing a tract called medial lemniscus, which is a tract that controls sensation in body parts. And relative to that, we are showing in yellow the spot that we need to ablate to provide relief in tremor surgery. And so certainly allowing us to improve our precision, but at a single patient level where you can track these different nerve fibers of interest before starting your intervention. And using this kind of approach, we had previously shown that you could improve the effectiveness of tremor surgery while reducing the side effects. And so another exciting advance for personalizing the treatments in our field. The next advance that I want to talk about is a major advancement in the hardware for deep brain stimulation. And so conventionally, the deep brain stimulation electrodes are, these electrodes are insulated wires that have 4 different contacts. These are the metallic cylindrical contacts that deliver electrical stimulation to the target, which is shown here in purple. And as you can see that when you select a specific location and prescribe certain stimulation parameters, the electrode is able to deliver electrical field around it in a similar to pretty close to a spherical distribution. So it's called omnidirectional stimulation, where the electrical field extends equally in all different directions. What we understand, though, is that there are aspects of anatomy where stimulation improves patient symptoms, and very interestingly, where stimulation can cause side effects. And so sometimes having omnidirectional stimulation works against us. And so you would want some directionality to this stimulation. And recently we had the development of what we call directional electrodes, where the electrical field can be shaped to be preferentially in one direction or the other. And selecting a direction which is more beneficial and causes less side effects, you can then improve patient outcomes. And so certainly here showing that we could reduce on this this extension of the omnidirectional stimulation and keep the stimulation within the target so that you then achieve a greater coverage of the target while minimizing any risk of side effects that extend outside of the target. And so certainly a major advance in our field. The other advance in our field is focused ultrasound ablation. And I would talk to you in greater detail about focused ultrasound. First, I'll give a brief introduction. And so it's a very transformational technology that allows you to do brain ablation from the outside. And so certainly you don't have to make a surgical incision or open the skull to deliver the therapeutics. You can achieve ablation from the outside. In fact, we could do ablation without touching a patient's head during this technology. And this technology is enabled by what you see in here is a ultrasound transducer, which looks like a helmet. So it is a hemispherical transducer with 1,024 what we call ultrasound transducers embedded within it. And each transducer emits, ultrasound beams. And all of these beams are then convergent or confocal into a single spot. And so there is a focal spot of this transducer. By itself, each of these ultrasound beams are harmless. But when 1,000 of these combine to a single spot in the brain, then it is enough for you to be powerful enough to make ablation inside the brain. And the key advancement that has allowed us to do this surgery safely is integration of focused ultrasound with MRI, magnetic resonance imaging. And so here in the picture, you can see a MRI magnet, which looks like a donut. And on the table of this MRI is a transducer of ultrasound. So it's a finished product of what you see on the left-hand side of an ultrasound helmet that's mounted on the table. And the patient's head can then fit in this ultrasound transducer. And you can use MRI imaging to study patients' brain anatomy, while also in real time, you could acquire temperature mapping to study how much change in temperature is enabled by the ultrasound that you're delivering for improving patient symptoms. And so you can titrate the ultrasound parameters to up and down, depending on what you see on temperature mapping. So very exciting technology. It's disrupted the field of movement disorder surgery. A lot of patient excitement and enthusiasm for focused ultrasound ablation. And I have a little video that I'm happy to share with you. And so we talked about it. It's in focused ultrasound is an FDA-approved treatment. And this treatment is incisionless. And so we don't need to have a skin incision to open the skull and deliver therapeutics there. And the treatment can be done outpatient. And so patients go home the same day after surgery. It doesn't require anesthesia, and the results of the treatment are immediate. And so this is a cartoon showing here what you saw earlier in a zoomed in version, where this MRI magnet is shown here in green, and the ultrasound setup is shown here. Patients have a stereotactic head frame placement, and it allows us to keep the head steady. And then we put the ultrasound transducer on top of patient's head. Once the ultrasound transducer is positioned, then patients are laying on the MRI table. And this procedure takes about an hour and a half to 2 hours. And during this procedure, patients are coming in and out of the MRI magnet for testing and making sure that their symptoms are improving. Some of the things that become of interest for this treatment is understanding how the skull is favorable or not favorable for the ultrasound to pass through, because skull becomes a critical factor in getting the ultrasound efficiently to the target. And as I mentioned before, we have about 1,000 elements that are available to us. And for example, in this treatment, you can see that roughly 978 of these elements are active for the treatment. And so we have a lot of ultrasound elements available for our disposal. And then, like I said, we need a good surface area of the skull so that we can efficiently transmit ultrasound. And we have metrics called the skull score that allows us to know whether the skull is favorable for the treatment or not. And so certainly we look at all these factors during the treatment. Once we have a good sense of how much ultrasound we have at our disposal and the skull looks good, then we prescribe certain parameters for ultrasound. And so I'm sure you guys are familiar with the equation between prescribed power and duration of how much power is then prescribed to, and how much energy that converts into. And as I mentioned before, using MRI, we acquire pictures like this, where you can see in green the intended target that we are trying to ablate, and with red is the volume of the tissue where the temperature slowly increased. And you can see in the line diagram the rise in temperature, as you can see here. And that allows us to understand whether we are making good progress and how much temperature we increase, and whether that's sufficient temperature, how much volume of the tissue is impacted, and whether that's enough volume that needed to be activated. Once we deliver ultrasound to a specific target, then what we do is we then go and check the patient to see whether the prescribed levels of energy were able to reduce patient symptoms, or if they are having any side effects, because we want to make sure that the treatment is safe. And the important thing about ultrasound treatment is that if you were to notice side effect in real time in a patient, you have the opportunity to move the focus to a different area. So as we showed here in this diagram, that you could move the focus to a safer area. And once you establish the safety, then we are able to increase the temperature. You can see here in red, and higher temperatures, then we can make these effects permanent. And so patients are able to then have long-term improvement in their symptoms, and they biologically we are able to restore the physiological state. The important thing is that this treatment has been done to over 10,000 patients worldwide. And so a very rapid growth in the number of patients who underwent focused ultrasound ablation. And a lot of patients are excited about pursuing this treatment in future. And this technology is certainly disrupting the treatment of patients with movement disorders.
So, have you used all of these technologies? Like, how new are these technologies?
Great question. And so the first application of focused ultrasound, you'll be surprised to know, dates back to the post-World War II era. And so in 1950s, Fry brothers used focused ultrasound to treat patients with Parkinson's disease. But at that time, there were several technological limitations that prevented the widespread sort of use. In late 1990s, Dr. Kullervo Heinonen in Boston then really spearheaded and is considered the father of modern focused ultrasound. For my field specifically, functional neurosurgery, the first testing of focused ultrasound began in early 2010s, 2011, 2012 in University of Virginia. And a large-scale trial then started in 2013, published results in 2015, and we had the first FDA approval in 2016. So if you think about it, for a larger clinical application, this technology has been around for around a little over 10 years.
Okay. So, how do you see the future of neurosurgery and neuromodulation evolving, especially with the advancements in technology?
That's a great question, and we in neurosurgery do realize that that technology has the potential to really improve the reach of our treatments, to make them precise, to make them better, and to improve our patients' lives. And there are several technologies that are at the cusp of doing that for our specialty, and we're very excited about it. Specifically for my specialty, I'm very excited about focused ultrasound really disrupting the landscape of treatment of neurological disorders. I wanted to share another slide about, what are some of the areas where I see focused ultrasound making an impact. And so this is a slide that we put together, looking at different biological effects of ultrasound in the brain. And so on the extreme left are the biological effect and the clinical applications that are mainly in research phase. And on the right side are the biological effects that are in clinical translation and clinical practice. And so thermal ablation, meaning that ultrasound mediated ablation of specific brain structures to treat neurological diseases is now in clinical practice and also being tested for a lot of research trials. And so the fundamental mechanism is that using ultrasounds, you then increase the temperature of the targeted area, and increase in temperature then leads to coagulative necrosis of the proteins in the cell wall, and that causes the ablation of that specific brain region. This has been tested and clinically implemented for essential tremor, as we discussed. Parkinson's disease is being actively tested for epilepsy and neuropathic pain and psychiatric disorders. Ultrasounds not only cause thermal ablation, they could also open the blood-brain barrier. So this is another critical concept, that the brain is protected by a covering called blood-brain barrier that prevents toxins from getting inside and affecting brain function. But this blood-brain barrier can sometimes works against us by preventing therapeutics to get into the brain, or it can dramatically reduce the efficiency of that delivery. So using ultrasounds paired with microbubbles, we can open the blood-brain barrier to improve the yield or improve the efficiency of delivery of therapeutics into the brain. And so we give microbubbles into the vasculature, and ultrasounds can then perturb these microbubbles and mechanically open the blood-brain barrier, which can be game-changing for patients with brain tumors and neurodegenerative disorders. Ultrasounds can also excite or inhibit brain tissue. And so neuromodulation with ultrasound is another fascinating area that remains to be tested and is actively being looked at for a variety of disorders, including addiction. Histotripsy is another mechanisms by which ultrasound can ablate very precisely brain tissue and can allow us to very precisely perform surgery in the brain, and can be a game changer in the future for epilepsy and disorders like brain tumors.
Okay. So what would you say are some difficulties in your field that you face every day?
Yeah, so that's a great question. And so, some of the challenges that come through are, implementation in clinical practice requires for us to test these treatments in large patient populations. And so that requires for us to undertake large clinical trials. And so that comes with its challenges of creating multidisciplinary teams, multi-center trials, recruitment of large number of patients, and testing these things quickly enough, but also in a careful approach to make sure that we get to test the safety initially and then look at the overall effectiveness of these treatments. And so it's a slow process, and sometimes requires persistence over time. And so the other aspect that we notice is that currently the way we diagnose diseases is based on looking at patient symptoms and sort of classifying a group of symptoms into a neurological disorder. And so our understanding of the brain network dynamics behind these disorders are not as mature as we would like it to be, where we could then very objectively diagnose individuals with certain network disorders and classify them into one group, while someone who's presenting with the same symptom but maybe different brain dynamics into another group.
Oh, that's interesting. So this is probably going to be my final question. So what advice would you give to young professionals or students aspiring to enter the fields of neurosurgery, neuromodulation, or related research?
The advice I would give is it's a very exciting field, and people should consider this. We need bright people. We need innovative thinking about some of these neurological disorders and the treatments and discovery of the mechanisms underlying diseases and looking at new ways of treating some of these disorders. And so these are very exciting times in clinical neuroscience. We are very excited that some of the discoveries in neuroscience are ready to be implemented. And so we need bright folks to be a part of this journey. It would take persistence, hard work, and you should be ready to do so if you want to pursue this field.
I know I said this is my last question, but I have one last question. How would you say teamwork is prevalent in your field?
That's a great question, and I'm a functional neurosurgeon, and I work in big teams where we have colleagues from neurology, radiology, neuropsychology, and of course, anytime you go to the operating room, anesthesiology. And so big teams that are required to work towards a common goal. You need ways to communicate with your team, address people's concern who may be looking at the same problem from different perspectives. Keep your team inspired, and be there to back up your team when chips are down, and also celebrate some of the successes that you may have as you go along. So critical teamwork is critical and very important for our field, and not only clinical medicine or functional neurosurgery. I would say that more and more research, again, is a teamwork where you need large teams to come together with a common goal to be able to test some of these treatments and bring them to clinical practice.
Okay. Well, is there anything else that you feel like adding?
I think we had a comprehensive discussion about some of the exciting advances that are coming in neurosurgery that improve our precision through robotics, allow us to personalize treatments to patient-specific anatomy by using advanced imaging, and then disruptive technology like focused ultrasound that helps us, access brain regions that previously were difficult to access with conventional surgical approaches, or help patients who wouldn't consider the conventional surgery before. And so exciting times in clinical neuroscience.
Okay. Well, as we wrap up this insightful episode of the Bio and Beyond podcast, I want to extend our sincere gratitude to Dr. Vibhor Krishna for sharing his wealth of knowledge and expertise. His groundbreaking work in neurosurgery, coupled with a commitment to research and innovation, is truly inspiring. Stay tuned for more captivating conversations at the intersection of biology, medicine, and technology. Until next time, this is Satwik Nath signing off from Bio and Beyond podcast. Remember, the exploration never ends. There's always more to discover.